everyone, and welcome back to OE Headlines, Ortho Evidence's new podcast show where we discuss trending topics within the orthopedic community. My name's Abby Payne, and I'm here in studio with my expert co-hosts, Dr. Mohit Bandari and Dr. Brad Petrozor. Hello, hello.
Hello, hello.
How's everybody today?
Oh, it's been a busy weekend, long weekend. What were you up to, Brad?
Well, I actually had a summer project, and I finished it this past long weekend. And my summer project was to make a stand-up paddleboard.
Ooh.
You made a stand-up paddleboard.
I did. It is behemoth. It is ugly, but it floats and
What'd
it
you
tracks.
make it out of?
I made it out of EPS, which is expanded polystyrene, which is a special foam, but it's actually not a special foam. When I found out that EPS was plain styrofoam and you can buy it at the hardware store as styrofoam insulation, I thought, I think I can do this.
How much you make it for?
How much?
Yeah.
Oh, I had too much because the epoxy was way too much. I probably sank $400 or $500 into it. Don't tell
Well,
me.
it's cheaper than a
regular one.
paddleboard.
Well, an
Yeah.
epoxy one that's properly laminated and all that sort of stuff it can run you a grand, a couple of grand.
Yeah.
But you can get inflatable ones for $500. So at the end of the day, did I really save a lot of money? But I certainly I learned a lot. That's for sure.
Yeah.
And it was anyway.
Amazing.
That's awesome. Well, I did.
Way productive. Like that.
I did not do that.
No,
You know
I
what
was
was
not
your
that
weekend?
productive this weekend.
I had only two things on my mind:
Yes.
Donda or CLB. So, Brad, you've got to help me break the tie. Donda or CLB? Which is it?
I barely know what you're talking about, to be honest with you, in
Okay,
terms of Donda and
maybe-
CLB.
Yeah. So maybe for our esteemed viewers,
Mhm.
talk to us about CLB. What does CLB mean to you?
Dude, it doesn't mean much to me at all. It means more to my teenage kids, and I know at least that it means something about Drake and something about Kanye West.
Right.
Other than that, that's it.
Okay.
That's all I got.
So if you had a comparison, probably it's not Donda or CLB. What would it be for you? What would be the two big albums that you'd be always debating?
Oh, that's a good question, actually. What is the
Back in
album that I'm
Black?
dating? No, that's not a debate. Back in Black, some of the albums by Van Halen, they're not debates. They're classics.
Okay.
So it's
So you're
apples,
telling me,
oranges.
They stand
so you're
alone.
going to tell Kanye West Donda's not a classic? Is that what you're saying?
Yeah, well, it's just released, dude.
Yeah.
Oh, I see. Okay. So it takes some years.
The jury's out.
Jury's out.
What
Okay.
about you?
Honestly, so
You have a robust knowledge of '90s hip hop and all the things
I have some
predated
knowledge.
this.
I know
So-
some knowledge in this area. I will tell you that Herm Joe Hall, as you know, and I were driving back from Montreal, and we put on Donda, and we just kept saying next. I thought, geez, this is really not. I just felt like it wasn't finished. And then I went back 2 days ago and listened to it again. And it's really good. It's really good. Now, Drake is Drake. Drake, as they say, Drake is Drake. Right. But but in this case, like he's he's giving you everything you'd want to get. I like tons of songs in there, right? But Donda has grown on me so much so that you see the musicality. Anyways,
Cool.
This is not about this. I
I'll give it a
apologize.
listen. I
Sorry.
will give it a listen.
And the evidence is out. But I can tell you, if you look at data as evidence, they're about just under 500 million streams each. So they're neck and neck. So maybe there isn't a winner. Maybe they're both winners.
Mhm.
We have an exciting show ahead, and we'll kick things off today with our OE Headliner story, where we will address ivermectin use for COVID-19 with special guest Dr. Zain Chagla. Then we'll dive deep into 5 common questions that are asked about COVID-19 vaccines. So first off, we'd like to welcome Dr. Zain Chagla joining us remotely. He is an infectious disease specialist at St. Joseph's Hospital in Hamilton, Ontario, and is an associate professor at McMaster University. So let's dive in. In recent weeks, the anti-parasite drug ivermectin has attracted much attention as potential treatment option for COVID-19. The meta-analysis out of the UK included 24 RCTs and 3,400 participants and was published in the American Journal of Therapeutics, citing moderate certainty evidence, finding that there were large reductions in COVID-19 deaths that were made possible using ivermectin. Using ivermectin in the early clinical course, it was also reported that it may reduce numbers progressing to serious disease. The study stated that apparent safety paired with the low cost is likely to have a significant impact on the SARS-CoV-2 pandemic globally. Dr. Chagla, what are your thoughts on this?
Yeah, so ivermectin has been probably one of the most controversial issues during the pandemic, and I think we go back to the preclinical studies, which in the lab did suggest there may have been a therapeutic effect. Now, the one major issue with the lab studies that has not been reconciled in clinical practice was that the dosing to actually get inhibitory concentrations of ivermectin for SARS-CoV-2 were well above the therapeutic range and well above the toxic range of what could be given to human beings. And that never really got reconciled. The drug got trialed in doses that were more conventional for human beings. And so we had a large network analysis that was done by the Surgisphere folks in the United States that showed a mortality difference. That study was eventually retracted as amongst a number of different studies from that Surgisphere group where there were serious issues about the data quality of what was being extracted. And then we've had a number of small studies come out with varying results, positive and negative, around the use of ivermectin. And so, different meta-analysis have taken a look at this. There's been one, as you've mentioned, in the UK, one that was published in Open Forum Infectious Diseases, and another one that was also produced. And they've had varying results based on their quality of evidence around meta-analysis. The bottom line, and I think what is emerging now, is the need for better RCTs and really well-designed placebo-controlled RCTs. We have a couple from Brazil that show no benefit in hospitalized patients. And I think that's reasonable. Antivirals don't work well when the disease process has been established. They work well at the beginning of the disease, not towards the end of the disease. But number two, we have a well-designed trial outside of McMaster, actually, that was done in Brazil and South Africa, this Together trial, which with a placebo control did not show any beneficial effects of ivermectin, a fairly large trial in that analysis. What I will say, though, is that the meta-analysis that are cited, the one that you talk about, and a couple of other ones, have cited a couple of trials that, when in looking at them deeply over the last couple of months, had serious data consistency issues. The NAI trial, which is the biggest one that was done in Egypt, had major data consistency issues to the point where the journal has actually retracted it and taken it down for the sake of some of this analysis not being optimal, and subgroups not being added up properly, and again, serious breach of what we think is the protocol for scientific research. Much of the other data is prospective, especially in the prophylactic arm, observational. So again, you're really not sure if this is same people at risk. Some of the risk characteristics, particularly for prophylaxis, you have groups that are getting COVID-19 at 70 to 80% in some groups, versus 0% in the ivermectin arm, which, in reality, outside of being exposed within a household, is not really a scientifically valid or really a community acquisition event, even in a high-risk healthcare worker that's using PPE. So, a lot of this stuff does have data inconsistencies. It brings up the need for really well-designed clinical trials. We have one in the Together trial in the United States. We will likely get another well-designed early treatment trial in principle in the UK, and two randomized controlled trials in the United States, the Active 6 trial and another trial that's being done there. And I think before those trials exit, there is not the burden of proof right now to say ivermectin is a standard of care or even effective in COVID-19, especially as you start taking out some of these fraudulent studies and doing the meta-analysis again, which is showing no effect. So for people out there, the data is being skewed. There is certainly a political leaning and a bit of counterculture that is pushing this drug. But really, when you break down that burden of evidence, especially at the levels of organizations like the World Health Organization, Health Canada, the FDA, the recommendation is actually to not take ivermectin for the treatment, prophylaxis, and post-exposure prophylaxis of COVID-19.
And that's really, really helpful. And it gets back to the old statement that I remember from master's thesis way back when under Professor Gordon, guy who I know you and I know pretty well, Zain. He said, a meta-analysis is as good as the data you put into it. So let's not get confused by the hocus pocus of the magicness of putting and combining data, let's look at the individual studies as you have carefully done. So I think that really sheds a lot of light on that issue.
So on to our Fast Five stories. Our first story, vaccine hesitancy is still an ongoing issue. And with vaccine passports being mandated across provinces and states, we're hoping to shed some light on the most commonly asked questions for those who are still on the fence.
Common question we get, Zain, is mRNA as a vaccine approach safe? We don't have enough data, like for some individuals, to say, and that's why they seem to be hesitant for the vaccine. What's your response to that group?
Yeah, it's a very reasonable question. And, I think people are looking for long-term data of safety. mRNA, going back to fundamental principles, is not much different than a protein-based vaccine, other than the production of the protein is at the level of the cell rather than at the level of a mass factory. Realistically, the same byproduct is there, whether or not you injected spike protein or mRNA that makes spike protein. The end result is our immune system reacts to spike protein, and that's what really causes the immune response. And so, I think fundamentally explaining that concept, mRNA seems scary, but to patients like DNA, but the reality is we make millions of molecules of mRNA in every millisecond for our body to stay alive. And again, the only difference in these vaccines, their bodies are the factory, not the actual commercial factory. But number two, I think people are looking for long-term safety data. And it's important to remind people vaccinations don't have long-term effects. They have short-term effects and side effects that we watch for as part of our data monitoring systems. But there's not been a single vaccine out there that's been shown to have effects 6 months, a year, 2 years after someone is inoculated, right? So yes, absolutely, that first 2 months of data is critical. And we now have nearly 1 billion people on this earth that have well more than 2 months of data in terms of that. So we've given this to a population, and largely more than many drugs that we even give in our history. And again, we've seen a track record of safety, except a couple of side effects like myocarditis, which certainly need to be watched. But for the standpoint of short-term safety, these are much safer than other vaccines and other medications out there, realistically. And again, compared to the long-term side effects of getting COVID-19, which we still don't know, it is well into the risk balance of benefit, a significant benefit to taking a vaccine.
I'd almost argue saying that, I can't remember a time in history where there's been so much surveillance on a vaccine. Look at the way in which AstraZeneca was identified, dealt with, and in many cases, some people just said, we're not going to use it anymore. I don't recall that sort of surveillance at such a global scale in the past. So if anything, I think the surveillance has been exemplary when it comes to sort of the vaccine rollouts broadly. Would you agree with that?
Yeah, absolutely. We've had 2 or 3 vaccines in the real full-on digital era that have come out, right? And this one in the most highly connected digital era and the most globalized vaccine probably that's come out in the last 20 years. So, again, absolutely. This has been monitored more than many drug products. The vaccine trials were actually bigger than many vaccine trials we have of our typical routine childhood vaccine series. So again, the data for safety is there. The FDA has taken the data for Pfizer and said, we approve of this drug, period, regardless of emergency use. And that's really, really profound to say, considering how many people have been vaccinated safely with these medications.
Okay, so another common question we seem to be getting is, listen, if I've already had COVID, why do I need to get vaccinated? What's your response to that individual?
Yeah, so absolutely having natural infection offers some protection against future COVID-19. I think that's a very reasonable statement. With the variants of concern out there, particularly with the Delta variant, there is immune escape that has been associated with this. And convalescent plasma, the ability for natural immunity still has limitations. There's a big study that was done in Kentucky in their public health department looking at people that had COVID-19 and had COVID-19 that were vaccinated. And the odds ratio for a second infection was higher in the group that was just natural immunity. It was 2 times higher. So people who were vaccinated still had a lower risk. I think that's enough to say that natural immunity short-term may be protective. There may be long-term elements that may be protected. The group that's out there in the world right now that is probably the most protected against reinfection is the naturally infected individual who gets a COVID-19 vaccine, where they have, as robust immunity as possible to this virus.
And then how about that individual? Another question we get asked is, well, if individuals who get vaccinated still get the infection, well, there you go. You see, I mean, what's the difference? If I don't get vaccinated, what's the difference? I still have the risk, and you do too.
Yeah, absolutely. And I number one, there was always going to be a risk of COVID-19 in our world. I don't think, even in the vaccine clinical trials, 70 to 95%, meaning that there was a group that got COVID-19 at the end of the clinical trial who got vaccinated. But, number one, it is a significant reduction. Cases in Ontario right now, there's a 6 to 8-fold reduction in cases amongst fully vaccinated individuals as compared to unvaccinated individuals. There's no other medical intervention that can reduce risk that much. Based on studies of masks, we think it's about 11 to 20% reduction. Based on other interventions, we don't have any other intervention that can prevent COVID-19 as well as getting a vaccine in your system. But even for those breakthrough cases, the healthcare costs, utilization in serious disease in people that are breakthrough infections is markedly lower. And again, we're talking 80 to 90% reductions in hospitalizations, 95% reductions in ICU stays, and obviously significant reductions against death. Again, of the medical interventions out there for COVID-19, if you were to get COVID-19 today, need hospitalization, or again, prevent hospitalization, there is no other medical intervention out there that is as potent as having a vaccine in your system if you test positive for COVID-19 to mitigating serious disease out there. So there's still a big rationale here to get vaccinated.
Totally makes sense to me. And again, I think, when I hear, you yourself as an expert speak to these issues, I think it does help clarify a lot of these areas where there may be debate, where really, quite frankly, I don't think there needs to be a debate. But let me go back to the issue you brought up early on, which is the long-term protection and or safety. We keep hearing about concerns with fertility. We keep hearing about, well, do I need a third booster at some point? How long is this going to last? And now am I just reconciling to yearly getting a COVID vaccine injection? What are your thoughts broadly on some of those issues?
Yeah, and so, number one, the fertility issue, the vaccines weren't studied in pregnancy at the beginning, but we certainly have data now about pregnant women who are actually prioritized to get the vaccine. So US data from the V-Safe system of 4,000 women suggesting pregnancy outcomes were exactly the same as people that weren't vaccinated, other than the fact that they got COVID-19 more, who weren't vaccinated. We now have data in first trimester around spontaneous abortions and miscarriages, similar rates as the general population in terms of getting vaccinated. And we now have fetal outcome data, again, suggesting no difference in fetal outcomes amongst women getting vaccinated. So at least we have now a spectrum of data of safety along pregnancy where we can, at 9-10 months after going to a vaccine series, we can definitively start saying that pregnant women offer, there's no documented risk to the fetus and the pregnancy, but a significant protection in pregnancy from COVID-19, which unfortunately is a risk factor for severe disease. And unfortunately, we've seen too much of. Even in male fertility, we now have sperm studies suggesting no difference in sperm counts in people who've gotten the vaccine or not. So, again, that fertility issue was something that was almost misaligned up front. We've done due diligence. Many research companies have at least put it out there, their research, to really show that there's been no adverse effects on pregnancy or fertility, both men and women. And again, the data is there to respect that, despite what, the Facebook forums and other things say.
Got it. And then the issue of the booster, like how long do you think the immunity is likely to last? And, I've heard that, Pfizer's applied, to the FDA to be able to give a booster. Maybe it's already been approved. What's happening on that front? Like for those who have already been vaccinated, what's the reality for them next year?
I think we probably are buying ourselves a shot or two down the line, partly because, as we know with viral infections, mucosal immunity, like at the level of the nose and mouth, is what's going to prevent us from getting infected. A vaccine may give you some mucosal immunity, but that probably wanes faster than systemic immunity. The good news is people that are vaccinated now will likely have long-term systemic immunity, so their ability to get very sick with COVID-19 is probably there reduced for some time. But their ability to block infection may not be there for as long as we would like, especially people who got the vaccine kind of on series, that 3 to 4 week, where I think we're learning now that the antibody levels were actually lower than people that actually got their dose spaced out a little bit. And so certain groups, I think those in the elderly age, where again, their antibody levels are lower at baseline. So again, they're going to be additively lower, plus an immune escape variant of Delta. They probably are due for a booster at about 8 months after their first shot. People who are majorly immunocompromised, they may not have even made a response to first or second shot, probably do deserve a third shot. Again, more to finish their series as compared to get a booster in that sense. But then, the vast majority of people that don't have major immunocompromise or aren't at the extremes of age, it's not clear. And at some point people will need it, but is it a year? Is it a year and a half? We don't know yet. And I think there's obviously important decisions here, given the fact that, the vaccine supply is limited. And there are lots of people in this world that haven't had access to a vaccine. And I think we have to be very careful about general vaccinations and boosters and what outcomes we really want to see. If we see slightly more breakthrough infections without any increase in hospitalization or death, I think we owe it for people to get their first dose first, as compared to people getting their third and fourth doses to boost their immunity.
Got it. And and the last broad question we get asked a lot about masks. Are masks just here to stay? So the individuals, let's say you're fully vaccinated, what's the added value to wearing a mask?
Yeah, it really does come to societal pieces now. And the fact of the matter is even with vaccines, we still have pockets of unvaccinated people, some of them, but not by choice, under the age of 12, but some of them by choice that are again at significant risk of healthcare utilization. And the problem is we still have a publicly funded healthcare system in Canada. And so, that has impacts on all of us if those people end up in hospital, taking up beds, putting off surgeries, that type of thing. And so, again, masking represents a population-based control to slow down the spread from vaccinated to unvaccinated people and unvaccinated people to unvaccinated people. If everyone unvaccinated could wear an appropriate mask, I think that would have been a better intervention. But the reality of the situation is we can't mandate it. We have to kind of do everyone in that sense. And so, I don't think it's here to stay forever. I think as we start saying those age groups getting younger and younger, getting vaccinated, as more people, unfortunately, who take a choice between vaccine and natural immunity, one way or another, get immunity, we're probably going to see a situation like the United Kingdom where, masks will eventually come down at some point. And so again, there are control now to make sure healthcare doesn't get overburdened by particularly unvaccinated people getting sick. But as we get more immunity in the population, they'll likely be less needed in the grand context.
And let me just finish off by getting your thoughts on what we're seeing in Canada. And I suspect we're going to see also similar, really strong regulation, right, around vaccination. So we're seeing universities are basically saying, if you're a student, you need to be fully vaccinated. If you're a hospital healthcare worker, you need to be fully vaccinated. A lot of government workers fully vaccinated. I mean, is this enough to move the needle where we need to be? And I guess the question is, if you are someone who is not vaccinated or hesitant to get vaccine, I mean, are you basically destined not to be able to do anything? And is that reasonable? Is that a reasonable approach to move people in that direction? I guess the question is, what are going to be the exemptions to this? Like, who will be exempt from not being vaccinated, I guess?
Yeah, so for mandates in places like healthcare, high risk settings like universities where we see disease transmission prior to COVID-19, it makes sense. We have to, in healthcare particularly, we have a duty to care for our patients. We have a duty to not make them sick. And, we have a virus that has the ability to infect not only colleagues, but patients. And so, it is a no-brainer. Mandates in healthcare are essential in order to minimize spread to healthcare institutions and patients, particularly who are vulnerable, who may not make a response to vaccines. And I think, again, you can look back to high-risk settings like workplaces and schools. And, we have to say we have a tool that makes getting back to normal in those settings a whole lot more palatable without necessarily dealing with a walloping healthcare demand. unfortunately, we do have to invoke them in a number of these settings in order to get them back to normal and get students back to normal life and get classrooms back to normal in that sense. And I think, as we get out into the community more and more into other settings like restaurants and gyms, similarly, masks come down in those settings. You're breathing heavily. There's a risk of transmission. We've seen major transmission events associated with them. It's hard to keep them functioning without this type of thing to let their capacity stay where they are and give them the chance to actually, do the economic work that they need to do to keep alive, to keep customers coming and to fill tables or to fill gym spots. I think there is a line though that we do have to draw. And number one, vaccination mandates and passports will get certain people vaccinated, particularly the 18 to 40 demographic, but it still misses out on people who are impoverished. It still misses out on people that are new Canadians, that are still a significant chunk of the people that still need to be vaccinated. And there's still a need for proactive, funded approaches to go into those communities with trusted providers and opportunistically vaccinate as much as possible. But number two is we have to be ethical too about how far we restrict people. And I think, again, people still need the ability to do their essential services like going into healthcare, getting groceries, going to a pharmacy, going to outdoor settings that are low risk to, where the risk of COVID-19 isn't great, or again, that they're essential for day-to-day life, that we do have to allow some choice there as part of that exemption. So there is a balance there, but realistically in this world, especially as we go inside over the winter, these settings become more and more dangerous, especially some of these leisure lines. There's very little tools we have left other than shutting them down, and I think we have the duty to invoke them as we are right now.
Listen, that is superbly helpful. Abby has a question to ask you before we close up. So I'm just going to get you in front of Abby here, and you can kind of check it out here.
Hey there. My question is focusing more on kids under 12. When can we expect a vaccine to be ready for those kiddos?
Yeah, so there are two trials ongoing with Pfizer and Moderna, and actually Novavax as well. There's been a little bit of a delay because the dose finding has been the major issue. And so whether or not the adult dose is adequate, or because of the side effects and little people being little people, we need a reduced dose to get the same immunogenicity. The trials are ongoing. Pfizer expects their data to be released before the end of the year and possibly the next couple of months. Moderna similarly by the end of the year. So, depending on when that comes out, when Health Canada approve it, it wouldn't be, off the table to say by the end of the year, we start seeing our under 12-year-olds, particularly our 5 to 12-year-olds being vaccinated, and potentially, younger than that, perhaps into the new year, but it's coming soon. And I would say, these trials are near completion, they're enrolled. So it's just a matter of data analysis and then follow up more than anything else.
Okay. And a follow-up to that, do you expect vaccines to be mandated for kids for school next year?
Yeah, I mean, it really does depend on what these clinical trials show. And if there is any type of safety signal, obviously we have to take that into account as part of it. If they're as benign as they are in adults, and the experience starts becoming, fairly reasonable and access is equitable, at some point, perhaps maybe by 22 September, we do talk about it as part of the registration for school, especially given that it is, unfortunately, the highest unvaccinated, high contact setting that we see out there. And, if we have an intervention to make it safe and make kids have a normal school day-to-day process without driving community transmission to the community, it's very appropriate.
Okay, wonderful. Well, I think that's it from us. Dr. Chagla, thank you again for taking the time out of your extremely busy schedule to join us, and we really appreciate it. So thanks again.
Wow. How was that for an interview, Brad?
That was great information.
And the whole time we're giving this, I know you're sitting there thinking, had he not been there, Mo was going to ask me those questions, and you would have been uncomfortable beyond
The seat
belief.
would have gotten hot.
It would have gotten very hot, right? So
Yeah.
I said, Brad, tell me about your take on vaccination and vaccine hesitancy, Brad. Give us the evidence, Brad. And I know you don't want to answer those questions. So it was
I appreciate
awesome. It was awesome.
Well, thank you so much, Dr. Chagla. We really appreciate you taking the time to join us today. And we're going to move on to our next story. which is Jacob Cannonier, American MMA fighter in the middleweight division for the UFC, suffered a broken arm in October 2020 during UFC 254. Matters became more complicated when the bones weren't properly healing after his first surgery. The break was eventually declared a non-union, and Cannonier required a second surgery with a bone graft and bone stimulation. He's now back fighting and has claimed that he has picked up where he has left off, shortly after earning a victory at UFC Vegas 34. So Mo, Brad, what's the evidence surrounding bone stimulation?
Well, we'll set this up a little bit because Cannonier, it was amazing what he actually did. And in an interview that he gave, and he was fighting Robert Whittaker, he said that he broke his arm, his ulna, in the first 50 seconds of the first round. He blocked a kick and took it right here and then broke his ulna.
So Brad, radius intact, so an isolated ulna, mid-shaft. Do you know if it's like a nightstick kind of thing, where just kind of hand up and then clean break?
I mean, we're making the assumption that it's a nightstick kind of thing where the foot came in and hit him like that.
Yeah.
Radius intact.
Okay.
But he made it through 3 rounds. He unfortunately lost that fight, but man, that would have been pretty crazy. So anyway, then he was plated, and then subsequently determined that you're right. He had a non-union and was replated. In his interview, he said, they threw the kitchen sink at it, including he specifically mentioned bone stimulation. But he also got a second surgery.
Wizardry.
What's that?
Being wizardry is what he.
Yeah, being wizardry as well. So I mean, what is your take on the evidence around bone stim, especially for this non-union type situation?
Well, I think you're absolutely right. So if you take a step back and look at where you can apply any sort of adjunctive treatment. So you've got a plated fracture, and you say, okay, how do we potentially augment the healing? Because you don't want it to be a non-union. In fact, nightstick fractures are particularly prone, right? Because of that, because they're held out in distraction a bit, because of the intact radius. As you know, I'm telling you stuff you already know, but you know the point, right? They're at risk.
Ulnar fractures non-operatively always take long.
Yeah, the risk, right? They're a high risk. So I can see why you'd want to have an adjunctive treatment. The question is, do you do it as part of a fresh fracture model, or do you do it as part of a fracture at risk or a non-union model? Well, we did a study, as you know, called the TRUST trial many, many years ago. And the good thing about it is we were able to focus on one area, the tibia fracture. And we said, okay, we weren't able to demonstrate acceleration of fracture healing, fresh fracture healing in a tibia. Now, does that mean that you shouldn't try for other things? Absolutely not. People have extrapolated that data well beyond where it should go. In terms of generalizability, it's generalizable to the fresh fracture, likely in this case, a nailed tibia, if you're being really, really clear about where you should use it. But the area of a non-union is very different, right? So in a non-union, if you look at bone stimulation as an overall entity, there's different types. There's electrical stimulation as a group, and then there's low intensity pulsed ultrasound. I'd argue that the evidence around pulsed ultrasound, just in terms of body of data, is probably bigger and large. But the point is, there's these two camps, and both have their comparisons. Let's just get rid of the individual comparison between groups and say overall. Well, if you look at the overall data for bone stimulation, the observational data saying people who don't, people who, let's say they already have a non-union, and let's say, Brad, let me ask this, by definition, what's a non-union to you? Before we jump into that, what do you call a non-union as an absolute?
Yeah, and that's debated, as you know, which is, I'm sure, why you're asking the question. But a classic way to define it is a fracture that has failed to progress in healing over a period of time, which can be debatable, with failure to progress over time. And some people say 3 months, some people say 6 months, etc. Yeah. And a lot of people suggest we shouldn't touch fractures. You, from your data and your trials data about your team's data about tibia fractures, suggest maybe we shouldn't be touching fractures within 6 months.
Yeah, right.
Now, they went in a little bit earlier. So
let's take a step back. In the absolute phase, so you would say if something is a non-union, it is unlikely to unite, in theory, without some sort of intervention. So the prior trials have said, if we have an established non-union and we then apply something to it and it heals, it's probably with the intervention. That's the observational non-RCT data that's out there, right? So let's say it's for lipus, or in this case, for Easton, for example. They say it's around 80%, right, efficacious. And then the skeptics would say, well, it's not a randomized trial. You couldn't randomize, so it's probably high. Okay, so Abby, let me do this experiment with you. So you have a fracture of your bone, hasn't healed. Dr. Petrazor comes in and says, okay, we're going to put you on the list. You've got some time, about, the wait list's long, it's about 3 to 4 months, but we have something we can offer you. We have something called pulsed ultrasound.
Mhm.
Safety profile, Brad, for pulsed ultrasound from your perspective would be?
Safety profile is excellent, to be honest. I think it's very, very safe and pretty much almost no risk unless you have an allergy to the gel that you have to put on.
So there's some cost to it, and
there's cost.
Yeah, there's some cost. So the
Financial
downside is cost, right?
But physically,
But if I tell you, hey, evidence says that it's about 8 out of 10 people who get it will heal their bone, will not need to have this surgery. Would you take it?
Yeah, and there's low risk associated.
Low risk.
Yeah, for sure.
Okay. What if I said, you know what? It's 50%. Let's just be really conservative. Say, you know what? Maybe the data is overcalling. It's 50%. So now there's a 1 in 2 chance that you can still get this healed before your surgery. Would you take it?
I would take it, yeah, as long as there was still a chance I could get surgery if it wasn't successful.
Absolutely. Oh no, surgery is always on the table. But the
Okay.
point is, there's 1 in 2 chance you don't need to have another major
Yeah,
reoperation.
for sure. Yeah.
Okay. What about there's a 1 in 4 chance? 1 in 4 times.
Yeah, I think if there's low risk.
The bottom line is
why
we
not?
can do it, right? There's
Yeah,
no risk
why
to do
not
it, right?
try?
And here's the point, right? So like there are some things where when the risk is very, very low and the upside is potentially high, that is the model, I think. And especially when the consequence of not trying means you have another major procedure, why not? So not totally untoward that that this would have made sense for him to go ahead and give it a try, and I'm happy it healed up for him, and I'm hoping he gets back to his old form in no time. But the other question is before we get to that point of a non-union, we should be looking at who's at risk, right? So when you think about who's at risk, and then that's maybe the real target for biologics or therapies like bone stimulation, lipus, for example. Who is that person at risk? And I put forth to you, Brad, that no matter what data we look at, whether it's, the early risk factors for a non-union, such as distracted fracture, complicated patient profile from comorbidity, open fracture, all that stuff, transverse fracture pattern, all that kind of stuff, right? That's okay at baseline. But when you look further along, let's say at 12 weeks, and you have a patient who's sort of not healing the way you want, you have so much more information. And that's when I think we become even more targeted and able to make decisions. So I actually think, using it right at fresh fracture probably doesn't make a lot of sense. Waiting till non-union obviously makes a lot of sense because there's a huge impact of doing it, but also there's a sweet spot in that patient population. Your thoughts on that?
Well, do you think there might be a cost effect? Well, my thoughts are that is identifying that patient and the sweet spot, because the problem is the sweet spot gets debated. My question to you is, do you think if we can identify that sweet spot and that patient, there may be a cost effectiveness to using this as regards further surgeries down the road?
Do you remember one of our grad students, Raman Mundi? Remember he did in fact, he did a study on that topic. It was his graduate thesis paper. And by the way, if you've not published it, Raman, please publish it. Publish it, because Brad,
look at that face, Raman.
Yeah, we can't quote it, right? We can't quote it. But anyways, that being said, that paper, if I recall, looked at the 12-week data, and so I think 12 weeks was a predictor itself. So the 12-week assessment of fracture healing was strongly predictive of what's going to happen in a year. So that's the patient at risk I think we're talking about. Okay. Before we finish up, I just have to clarify one thing. So the paper that I was talking about, our esteemed colleague, Dr. Raman Mundi, in fact, is published. I was just kidding around that. So for those of you who are interested in that paper, I think it's a potentially interesting read. May 27th, 2020, published in the journal Curious. And the title is Association of 3-Month Radiographic Union Score for Tibia Fractures with Non-Union and Tibial Shaft Fracture Patients. So that's the paper I think is particularly important in moving the idea of patients at risk forward. So it's a good read.
Okay, wonderful. So moving on to our next story, track and field's biggest what if, Sha'Carri Richardson, had a quick rise to the spotlight this year. Her Olympic dreams were crushed after she was banned from competing at the Tokyo Olympics due to cannabis use. Richardson has now returned to the track, but seems to have lost some of her steam, finishing last in the Prefontaine Classic 100-meter dash, finishing at 11:14. And for her, just for reference, for the Olympic qualifiers, she finished at 10:86. So do we think that this is simply a loss of competitive momentum after her ban from the Olympics, or is there something else at play here?
Well, I'll jump in first. I think the whole issue of cannabis is a bit of a red herring here. And I think the focus is so much on cannabis. My impression, Brad, would be that it has very little to do with the actual, cannabis itself, and has more to do with sort of that short period of layoff and that competitive edge and that mental aspect of elite Olympic level athletes. That that 3 or 4 week period can completely transform you from a gold medalist to someone who in this case is having some real challenges in races. Does that mean in my mind that she can't get back to that form? Absolutely not. She can get back to that form, and we all wish she does, because she's got the capability. But on a broader note, it gets back to the mental aspect overall in sports. And haven't you noticed that we're seeing a lot more awareness around this? We're seeing it in tennis, we're seeing it in football, we're seeing it in baseball, all these areas, right? But particularly, we're starting to see it in Olympic athletes. Many examples of athletes.
Well, I think it's a testament to society today and people being a bit more in tune to those sorts of things, because they're under a lot of pressure from the beginning and from the get-go, and they have to deal with the pressure. And now that I think people are actually realizing, oh, maybe those pressures are affecting people, and they're not the stoic athlete that pushes through all the pain always that they may be, and there may be some underlying things.
Well, so I did look up some of this stuff, and I think I'm curious what your take on this is. So we have this, and to your point, right? We have this perception that, in the elite athlete, that it's a separate special group. In many ways, they are a very separate and special group, but really they're a sampling of our population. So if you look at rates of mental health issues in our population compared to athletes, I think it's an interesting dynamic. And there's been publications, and we'll make sure we post these publications for you on some of our notes. But depression affects about 6.7% of today's adult population over a 12-month period. The prevalence rate of depression among college level athletes ranges from as low as 15 to as high as 21%.
Wow.
Okay. Combined anxiety disorders affect the general population at an estimated rate of between 10 and 12%, right? With similar rates among elite athletes. So it's, you can argue there, but here's the interesting point. ADHD, so attention deficit hyperactivity disorder, may be more common actually in elite athletes than in the general population. And in fact, the argument here is, it kind of makes sense, right? You put these children as a treatment or a therapy, to say, be active, get out there, and they put them in sports very, very early. So there's a systematic review of about 17 studies of individuals with children with ADHD that demonstrated the prevalence of ADHD in athletes aged 15 to 19 years range from 4 to 8%. And this is way more common, multiples more common than in the general population. So to think that our just health and well-being and mental health and well-being is not an issue and should not be a priority, in athletes is it's just missing a real opportunity to do some good here. And we're seeing it, right? We're seeing it with Naomi Osaka. We're seeing it with a number of other individuals who are just applauding athletes, saying, we're human and we need help. And I think when coaches figure this out, teams, owners, and the fans figure it out, I think we're going to have a much better situation.
Yeah, no, I agree. And I don't mean to be the old man here, but I don't know what role the whole social media thing plays with athletes. They're different than, I would say, celebrities who have teams that can look after that stuff. Often, I would think they're looking after some of their own platforms, and you can have highs and lows and vitriol and just back and forth from that, just continuous feedback, and it's both positive and negative. That also can just help just undermine your thinking about what you're doing sometimes.
Well, that gets back to, I think, if you look at the case of Naomi Osaka, I mean, where she got a lot of interest in her area was that she said, I just don't want to deal with media. I'm a super amount of stress, and dealing with media after a loss is not good for me personally. And, and that is a pretty brave thing to do, because that in many ways, if you're a leading athlete, you are in many ways your sponsors want it, and the organization wants it, right? And it's an expectation.
And that brings it into that feeling of being not helpless, but feeling of being boxed in, that you have expectations that you have to manage, and that weighs really, really heavily. Not just the loss.
But that gets into any combat sport and 100%. Use of opioids, the combat sport use of painkillers, because you have to get out. I mean, like, in the UFC, not to keep diverting it away always to the UFC, but I know you know lots about this particular area. But it seems to me that being tough is critical. So if you go in there and you break a bone, you keep fighting.
Yeah.
The fans like that, and you're going to get more views. You're going to get more fights. The minute you look up for your personal protection, and there's an example. I don't remember who it was, where in the third or fourth round, I said, you know what, I don't want to go out, and the coach said you can go out. I said I'm not going to go out.
Yeah.
And this person was vilified.
Yeah.
Because they said, what do you mean you're not going to go out? Your coach said you're fine. Get out. And then they attacked this individual.
Right.
But he knew for sure
Yeah.
that this is not good for me to go out right now.
Yeah,
right?
and that affects
That's
both
the
parties.
problem.
The coach is supposed to be looking out for his fighter, but then your fighter doesn't want to go the same with the ref. Yeah, it's and the fans would look down on that sometimes. So yeah, it's hard.
Okay, so on to our next story. A new and extremely dangerous trend has gone viral on social media. The Milk Crate Challenge is a video challenge that involves stacking milk crates with both sides of the structure functioning as stairs. Individuals try to cross the structure without falling, obviously failing most of the time, making it extremely dangerous. This trend has orthopedic surgeons and ER doctors begging people to stop. Injuries include the works. We've got broken wrists, shoulder dislocations, ACL and meniscus tears, as well as life-threatening conditions like spinal cord injuries. So at a time where surgical wait lists are so long and COVID hospital admissions are so high, what are your thoughts on this, Mo?
How is this even a thing? I don't get it. Like, how is this even a thing? Like, why are we even debating and discussing this? But it is a thing. And I guess back in our day, we had our own version, right? Maybe jumping off the roof, right? I mean, as you climb up and you try to come down and someone would do something.
That
and
stuff still happens.
It still happens, right?
Yeah,
jumping off rocks, jumping into water. I get it, right?
Yeah.
So it's about milk crates. I don't personally get it, but I do see the amount of damage it can do. And again, we're not talking like, what is it, 6 feet is the top height? Did you guys know the height, how high it goes?
Looking at them, there was probably 6 or 7 crates stopped in there, about just about a foot each, right?
Yeah, so let's say 7 feet. A fall from 7 feet is serious damage. I mean, serious damage at every level, right? So you can totally anticipate that. A lucky fall, you'll be okay, but a bad fall, you're going to break stuff.
Now, Mo, there are some people who do this who don't get hurt, right?
There have to be.
Right. So apropos of our last podcast, do we need a randomized trial between this and not doing this to see if milk crates are bad?
I see your point, but I think it was you who very, very thoughtfully said something that Gordon Guy touched on, right? And I know that you baited me to do this, so let's use this little back and forth. Okay, Brad, I know you have the answer. So why don't you just say the answer? You wanted to bait me into this? Okay.
Brad, am I asking?
Brad, I don't know, Brad.
I still think we can see a clear treatment effect of lots of broken bones and injuries. And you're right.
And who taught you that?
Gordon Guy.
Thank you very much. That's 100th time. No, that's awesome. Yeah, that's true. And you're right. I mean, yes. But it's going to get views. And it's going to get, quote, likes. It's going to get all kinds of interest. And we have a army of individuals out there who are looking for content, and this is great content.
Well, thankfully, TikTok has banned the challenge from their platform, so you can no longer view these videos anymore on the TikTok platform, which is good.
And actually, getting to your point, just briefly, also is that this type of injury, like if you remember at the time when we were into the first and second wave of COVID, you couldn't mount back, couldn't do anything that would put at risk, and our community said, don't do anything that puts you at risk of potentially going to emerge and using space right now that is unnecessary, we might need for patients, right? So I think at a time where we're starting to see potentially a fifth wave coming, albeit we hope it's not a serious one, you want to be careful, and the last thing you want to do is put yourself at risk for no reason, and take up valuable healthcare resources.
For sure.
Okay, so on to our fifth and final story. Soft tissue injuries seem to be a current trend in the 2021 Women's US Open. Just this week, Bianca Andreescu battled through a 3.5-hour tennis match while suffering from a soft tissue injury to her left leg. And just a few weeks before, Serena Williams withdrew from the US Open, citing a torn hamstring. So Mo, what's the return to sport process for a professional athlete? And second part of the question, are there any long-term complications after repeated soft tissue injuries like these?
Yeah, so I think in both cases, it's well. First of all, we have to differentiate an elite athlete from an amateur. So at an amateur level, it's going to be generally it's going to be a protracted course. Why? Because if I get injured, I will take appropriate time away from sport. I don't have a reason to be jumping back, doing things. So I'll take a break. So if I'm playing tennis and I had a quads injury, I'm just not going to play. That's it for me. At an elite level, though, I think this is what happens. At elite level, there is an absolute urgency to get the player and the player for themselves get back. There's lots at stake for the host of reasons we've talked about. So what do you do in that situation? Well, if you talk about for most injuries that are non-operative, it's time, right? It's time, it's physio, and you need the body to let itself heal. In the simplest way, when you're an elite athlete, we have to find augmenters. Same way we talked about Cannonier and getting an ultrasound, we find a way to get this in, or a bone stimulation, or ultrasound, right? Do it. Your same thing. If there's a soft tissue injury, for example, if you remember, PRP, platelet-rich plasma, got a lot of popularity after there was an image of a football player with a soft tissue injury in the thigh, and you could see someone PRP and saying that person went right back out again. Tiger Woods, getting PRP in his knee and then getting out, and I believe he won, the tournament thereafter. There's a lot of pressure, and that's what gets these biologics rapidly in there. So, not to deviate from your primary question, which was, well, an elite athlete, what's the recovery? Well, the recovery for most elite athletes, no matter what you do, they're going to get back to pretty good level play. Are they going to get back to championship level play to keep winning? Who knows? But the reality is they're going to get back. If you look at Bianca, for example, her history is actually quite interesting in that, she has had numerous injuries. And so, but you can also argue she has had a huge amount of pressure to get back on the court and a lot of people attending to it. So yes, I think there are situations in which you're just not going to get back to the same level of play. And an initial devastating injury, unless you truly rehab it appropriately with time, it's just not going to get better. So I don't know, Brad, if you have anything else specifically to add, and it doesn't have to be about the quads or the hamstrings, but foot.
No, it's just but it's just about the athlete and the injury, and they get so used to I don't know them all obviously, but you hear they get so used to playing with pain, and so I would argue that yes, they take time, but you're right, they don't necessarily always take the amount of time, and you can have real problems in tendons with chronic inflammation and changes down the road and that sort of thing. And you mentioned lower extremity and the Achilles. Even then, we know that when Achilles can tear and professional athletes get fixed, still 17% of them don't get back to play, at least not at the level that they were at. That's like 1 in 5 people. It's not insubstantial.
And those who get back to that elite level are probably in many ways still tolerating. Like, you're never perfect again, right? I mean, with severe injuries, right? So it's a matter of, okay, how do I manage the pain? Some people manage it with just, grit. Some manage it with analgesics. Some manage it with just, live. That just my new normal.
Right.
But it speaks to the mental health component as well. I mean, imagine being on the court, everybody, all eyes on you, not just the people in the court, but on TV, your opponent's there, and you got to play and you're in pain. It's a hard situation.
Right.
Really hard. Yeah, absolutely.
Okay. So before we wrap up today's episode, we did get a question from a user. It was a follow-up from our last OE headliner episode on one of the Fast 5 stories, a new gold standard for humeral shaft fractures. So the question is the violation of the rotator cuff in a young patient treated with a nail for humeral shaft fracture a concern? Brad?
Well, the short answer is yes. The debate has always been between a nail and a plate, whether one is going to be better than union for the humeral shaft fracture over another. But there has never been a debate with the fact that a nail results in more impingement and irritation to the shoulder than the plate. And that signal has been consistent through every meta-analysis, I believe.
And if you go back to, let's say, the hip area, where they had the original piriformis nails, and they said, okay, without, the abductors are getting, rattled here. What about using a piriformis approach sparing, right? So a troponteric approach. Has there been a similar evolution of implants or attempts in the proximal humerus?
Well, I know that there have been attempts with the proximal humerus with the, those nails that are flexible, but it's not flexi nails like Nancy nails.
Right.
It's a multi-segment that has a wire inside that you can then tighten and make it rigid. I know some companies were experimenting with that to keep it out of the rotator cuff, but I'll be honest, I don't see that as being a mainstream nail these days, and I don't know how successful it was or if anybody's using that kind of nail. The standard is still to come down through the trochanter, the tuberosity, sorry.
Got it, yeah. And the evidence still is, the gold standard in 2021, when I say gold standard, the current standard would still be the plate?
I would argue the plate, yeah.
Right, fair enough. That's pretty good.
Well, that's it for our show today. We'd like to thank the OE community for tuning in, and a reminder to send any questions or topics to headlines@myorthoevidence.com. Dr. Petrazar, Dr. Vandari, thank you so much for joining us, and a special thank you to Zain Chagla, who joined us remotely this week. Thank you, everybody. We'll see you next time.
Awesome. Thanks very much. Cheers.